Hello? Shall we start? Hello, dear ladies and gentlemen, dear guests of the 18th Assembly, Healthy Moscow. We are having the third day of excellent big assembly, which is an international event. It brought together over 200 specialists from different countries, from all over the world. The assembly has over 300,000 guests that visited this event, over 1,500 news and publications. In fact, you can get to know at this assembly not only about the achievements and innovations, you can meet new people and exchange your experience and get very useful practical knowledge. This session is called Brain Diseases, from basic science to clinical practice. But before we start this session, I would like to share some results of our festival of doctors. It is held by the Department of Health and they have been holding it since 2012. So today we are going to share the results and give awards. And I would like to give an award for the best neurology specialist nomination. This diploma has been signed by the Minister of Health of Moscow government, and I would like to invite Alla Avideva, who is the head of scientific center named after Soloviev. Thank you, colleagues. I want to get back to my place so that I could see you all. Thank you very much. Our center has been holding this symposium for the third time, and I always start my address with thanks to the Department of Health, because it's a great congress. It's a real celebration, so we are always happy to see so many people. So I'd love to thank the Department of Healthcare and the mayor's office. So it's great to see our international colleagues, and this gives very good potential for our professional developments. Oleg Artykhov is a great specialist. I know him very well, and it's great to give an award to him because he is really one of our best specialists, because this symposium demonstrates best developments in science and practice related to brain diseases. So I'm sure that we'll continue this. And let me introduce Nikolai Shamalov, who is the chief neurologist of the Department of Healthcare, professor, doctor of science. If we would be happy if you could say a few words. Good afternoon, colleagues. Let me welcome you at such a representative event, this assembly that is held on a very high level. We have been here for the third day, and we can see many different events, many different sessions about different fields, and this brings us together, and it makes us a multidisciplinary team of specialists. And Alla is one of the main organizers of this event, so we have started this session with award ceremony, and it's a nomination for the best neurologist of Moscow. Thank you. Thank you for your welcome. And we are having Artykhov Oleg, who has been a winner in nomination. of the best neurologists. So if you could stay there for a few seconds so that all the pictures could be taken. My best wishes for your future development and professional growth. I hope that we'll have more assemblies like that, and maybe we should come up with a special initiative. You know, neurology is one of the most significant disciplines, so maybe we should award 3 prizes, like because they all deserve these prizes. But anyway, we would like to give my congratulations. Thank you, Oleg. Would you like to say something? Let me thank you, colleagues, for your appreciation and recognition. And I would like to thank my department and my colleagues who helped me to achieve this. It's great to work with you guys. Thank you. Okay, thank you, Oleg. Thank you, Alla. So before I give the floor to Alla, who is going to start the session, let me introduce our international guests. As you probably know, the 18th Assembly Healthy Moscow is a very important international event, and we are having 2 very important guests. Didier Leis, who is a professor working at University of Lille, editor-in-chief of the European Stroke Journal, and Reta Calvinanian, professor at University of Kuopio and director of the Epilepsy Center at University Hospital. Let us welcome our international guests. And Alla, now the floor is yours. Colleagues, thank you very much. It's true that we are going to start this session about brain diseases. Actually, this has been a traditional title for many events that take place all over the world. And I'd love to say that we are going to have a big event on the 1st and the 2nd April at our center. It's going to be a big conference. It's going to take place in Buyanov's hospital. So if we don't have enough time to discuss certain things, you are welcome to take part at our next conference, because it would be great to continue our discussions. So thank you once again for coming, and I'd love to thank our lecturers and international speakers. It's great to be here, and it's nice to hear about new areas of development that our Alexeyev's clinic is doing. So we are having we have to stick to timeline, so you can have 12 minutes. And Marina will show you that you have to come to an end, otherwise we won't be able to listen to all the speakers, because we have a very intensive program. I would like to give the floor to Rinat Akhizigitov, who is the deputy director at the center named after Solovyov. So he is in charge of many programs that take place at our. So our center is famous because we have integrated the neurological and psychiatric care and support. That's why we position many issues as multidisciplinary. And this symposium has this title, brain diseases. So I'm a psychiatrist, and that's why I'm going to speak about depression. I need a clicker. Where can it be? Can you give it to me? So the problem of depression is quite complex. It has many aspects. But before I tell you details about depression, I wanted to mention that the UN had a third meeting of a high level in 2018. So it used to be 4 groups of non-infectious diseases that had the biggest importance. And as to the third meeting, the psychic disorders joined this list of diseases. It means that this pathology is growing in the world. And now let's get down to depression. Of course, everybody knows what it is. So we say and we understand that depression is growing, and by 2050 it will become the main reason and will be on top of cardiovascular diseases. We should talk about depression. Those people that suffer from depression should talk to doctors, to psychologists. They shouldn't get close. They shouldn't stay away in isolation from others. So the doctors should discuss it. General practitioners and therapists should discuss it with their patients. We had a plenary session on the first day of assembly, and you probably remember that Larson said that the share of population that is living in constant stress is always growing. So there are also many people that don't have enough sleep. They can have only about 7 hours of sleep, whereas there should be 8 or 9 hours of sleep. And it means that this will produce additional stress for them. But if we take a look at the official statistics, I'm sorry that you can't see it properly, but basically this is the figures from Rosstat, and psychic disorders are here in the middle. The number of people that couldn't go to work due to some psychic disorders. So we see that figures go down from 130 to 109,000, and then 2.9 million days went down to 2.4 million days. So it means that actually there are less cases of depression and psychic disorders. How could it possibly be? And the Russian Society of Psychiatrists published an article on their website asking whether it's a trend or an artifact, and I'd love to prove that it's an artifact. It's true that formally there are less people that get sick with this. There are less records in medical journals just because of stigma. People are afraid of psychiatric care, and they are afraid of psychiatrists despite a lot of information. This service is not available. Many people will be afraid of going there. Not many people know about us. There aren't any psychiatrists' offices in regular clinics, and multimorbidity of boundary psychic pathologies. You know, it's not always that the patients admitted to themselves that they are suffering from depression. Another quotation that I wanted to give you from the plenary session that took place on the second day. So Dmitry Peskov said that there is a mass scale trend against hyper-personalization of data. So people are afraid of sharing their data with the internet, even though people try to convince us that our data will be protected, but we understand that there could be some crashes and hackers might get access to our data. That's why people are afraid. What if the employers find out that their staff members had depression? What if somebody, some friends found it out and would start laughing at you? And Dmitry Peskov mentioned that the automatic face recognition should be banned in EU for 5 years, because this violates the right for privacy. Now, somatic issues or psychic issues. You know, it's very often that patients feel easier to speak about their stomach disorders or headache, but not about depression. Whenever we consult our patients, whenever we give consultations, we can see that there are a lot of somatic diseases that our patients have, because there are many connections between them and there are many pathologies that come together. Then food behavior disorder. Overeating is a chronic stress, and undereating is also a big problem that can threaten life. I'm sorry that I'm moving so fast. Then depression and epilepsy, again, closely connected pathologies. Our center is carrying out a lot of research with Columbia University, and you can check them if you are interested. Then stigma, if you have epilepsy, this is again a big problem, and epilepsy is stigmatized just like depression, and there's a lot of work being done by my colleagues. Then somatic and neurological disorders. They also have a very high probability of depression and suicidal risk. Our country is one of the leaders in terms of suicides and self-harm. Here you can see some figures that shows you the situation in 2015. Of course, there are some regional characteristics, and our country is not the only one. Japan has their own cult of harakiri, but it's terrible, isn't it? So alcohol affects this, and the anti-alcohol campaign that we had in 1984, 1985, you know, we cut out a lot of grapeyards that were growing for years. But look, the rate of suicides went down. And now, getting back to the plenary session on the first day, the Minister Skvortsova said that the consumption of alcohol went down twice. By 2 times. So it means that the Ministry of Healthcare is trying to develop investment cases, discussing that we should increase taxes for alcohol and tobacco, trying to stimulate healthy way of life and protect the health of our citizens and develop a healthy lifestyle habits that could improve their life and expand their life span. So emergencies can also be a very important reason for depressions, and this again can cause different disorders and diseases. Whenever some dramatic events happen, people don't get sick straight away. Sometimes it happens in a month or 6 months later. So this is what we have to remember and monitor. Children's stress. We conducted some research to identify traumatic events that influence children's development, and the way this person develops relationships in future life. So family plays a very important role. Education and environment is one of the mechanisms for psychic disorders.
So I don't have much time, so I'm skipping. So religion and spirituality, they're also protective factors in terms of depression. So families where people who are religious and who have some spirituality, they are less touched by depression. Of course, also genetic research. A big breakthrough is made. Some loci are opened when there is some predisposition to depression, more or less. But as we discussed with Professor Lates at another med talk, for now, when we can't efficiently treat it, should the person know about it? It's a big question, because the knowledge can become a reason for depression. Just a couple of words about our center. It's 105 years old. It started with these 2 small pavilions. They are still working. We have a huge in-clinic base and outpatient base. We have practical and research work. We also educate, and a couple of works about the conference that will happen on April 1st and 2nd. We are inviting you all. Thank you very much. Thank you, Renat. A wonderful speech. If there are questions. So in the first front row, you can ask our employees all the questions, because they can give you all the information you need. Our center has some specific trait. It's a multidisciplinary center. We have not only neurologists, psychiatrists, we also have clinical pharmacologists, physicians, because without it it's impossible to treat brain diseases. And with great pleasure I'd like to give the floor to Violetta Mukherjee, professor. Violetta is the head of great department, and she's a clinical pharmacologist. Without clinical pharmacology, it's impossible in the modern world to treat a patient. Dear colleagues, I'd like to be sorry that my speech would be just to highlight some issues, but I'd like to also to show some possible solutions. First of all, the main issue is the lack of classification of menopause issue diseases, and so all the diseases that we have in country, they're all very relative, because symptoms can be very early and they can go for years. And when there is this climax disorders, that can look differently. So what we can see here, it's very, very relative. So classification very relative, mostly approved by gynecologists, then all other specialists. So here you may see all the classifications, and I'd like to say that classification of Vyhlyeva that we have in Russia is mostly interested about one symptom related to blushing and hot flush. For instance, bradycardia or dizziness, it's already the moderate severity. But if it's over than 10 hot flushes, it will already severe form. So menopausal index by Kupperman. As today we are talking about vegetative disorders. Here you may see quite a lot of things that related to this autonomous nervous system. So here you may see 58 points. If we have a look at hormonal shifts, for instance, FSG level increase and reduction of be inhibited in the follicular phase of the periods. But we can look also at other hormones and decrease of estradiol and estrone and many others. But the main thing is that the state of the hypothalamic centers is changing, and the regulation and production of hormones and interaction is changing, and also the sensitivity of organs to hormone impact changes. And of course, this autonomous balance changes, so the whole institute should work on this issue, and this issue for now is not developed at all, and now no one works with it. So just to raise awareness about this issue is already very important. So climax is considered this adaptation disease. So not to break our adaptive mechanisms, it's important that a woman can adjust, can adapt through her own strength, but not with replacement hormonal therapy, and to bring her to a positive state, but at the same time breaking all the adaptive mechanisms she has. Unfortunately, we can't talk today about very clear pathogenesis, because there are so many changes, so various changes, that to create a very clear structure of this climacteric syndrome is almost impossible. So what are people trying to do? They're trying to understand the mechanism of each specific symptom. For instance, for hot flush, migraine, dizziness, headache. But you can't give the drug for all these different drugs for every symptom. But to recommend just one drug is very difficult. So today we reviewed the attitude toward the climax syndrome, and now only blush and sleep disorders and vaginal dryness is considered as symptoms. And all the rest is to be discussed. Is it climax disorders? Is it some consequences or some weak chains? So to look at how many specialists these patients go: gynecologists, endocrinologists, physicians, endocrinologists, neurologists, cardiologists, psychiatrists, psychotherapists, urologists. And each specialist solves this issue on just their side. And it's quite rare that these women come to gynecologists and endocrinologists. I'll show you non-medical therapy. Of course, it's compliance of this job and rest regime, physical activity, morning exercises, remedial exercises, walks, diets when we limit the easily digested carbs and fats, especially saturated fat acids. So water procedures like contrast shower in the morning, swimming, circular shower, a warm bath, rest at some resorts, and all kinds of special baths that was made during the Soviet Union. So that was competing with this hormonal replacement therapy. So neuroleptics, tranquilizers, selective inhibitors of serotonin, vitamins, amino acids, and phytoestrogens. That's what usually used today as when we talk about non-hormonal therapy. If we speak about neuroleptics, it's mostly for psychiatrists. So physicians and other specialists will quite unlikely prescribe it, take into account the side effects. As for tranquilizers, look how many we have. And if we talk about diazepam or other benzodiazepines, they remove climax symptoms, but you can't walk or live using such, taking such drugs. You are getting sleepiness, coordination disorders, and all other side effects. And especially getting used to them. So we can't prescribe them for a long time. There is a good role of day tranquilizers and Adaptol and Mebicar from other groups, because Adaptol is a bicyclic group and it has antioxidant properties and it's natural for human bodies. And this tranquilizer doesn't have myorelaxant and coordination violating effect and sleeping effect, so you can work quite efficiently. And the therapy, because so it does not metabolize in the body and is discharged unchanged, half by kidney, half by kidneys, half by through gastrointestinal tract. So we can prescribe this drug with any other drugs. There is no addiction, and we can make this therapy for 3 months in a row, unlike other benzodiazepines that just for 1 month. As a sedative disorder, it's important because all the sedative mechanisms of the body can start working, because sometimes because of some short therapy with other tranquilizers it's not possible to achieve. That's why Adaptol is a good one to start with. As we don't have much time, I'd like to show you its efficiency. Look, please. So the most important, it was good with all these hot flushes, and you don't have to increase the dosage depending on the stage of the climax. Is it mild or severe? And you have to wait just for a week. If there is no effect, then you have to cancel the product and use another tranquilizer. It's very important, and I'd like to say that besides Adaptol, we also studied about the usefulness of using neurotropes for these patients, because they are being prescribed quite, and we compared Serapitam with Phenibut, that has both qualities, no trope. So tranquilizing properties work much more efficient than neurotropic action. So this reduction of readiness and of being tired, it's also a property of neurotropic. So all the rest symptoms stayed the same. So it's just some confirmation. So we published it in a medical journal. So this large prescription of neurotropic drugs in climacteric period is not justified unless there are some other indications. If tranquilizers are not efficient, or efficiency goes away very fast after cancellation, venlafaxine, paroxetine, coaxil. So it's antidepressants. So only if it all doesn't work after very thorough gynecological and endocrinological study, after study the hormonal profile, then we can prescribe hormonal replacement therapy. Only gynecologists and endocrinologists may prescribe it. Gynecologists like to prescribe it, but they are not very good at understanding. For instance, if this progesterone will become androgen or estrogen, it depends not only of if it's a product with one action or another, but also on sensitivity of the patient and reaction to the drug. And on the other hand, we should understand that it should be constant therapy, and it's a lot of side effects. Strokes, ischemia, clotting. So only professional visit to gynecologist and endocrinologist can lead to hormonal replacement therapy. Thank you for your attention. Thank you very much for your encouragement to be professional. That's what we are trying to do everywhere. I agree with you. Everyone should be professional in what they are doing. So today we awarded the best neurologist, and of course only professionals should work with patients. Our next report, we work a lot with different chairs. First of all, So, with chair of neurology, neurosurgery and genetics under Ivan Gusev, and a lot of questions, especially big issue of cognitive disorders. You know, in our center we have a whole department, whole unit that are working with it, and Violetta, one of the heads of developers of such topic. And there are a lot of studies together with we make together with the chair, and I'd like to introduce Vera Alferova, MD, one of the biggest specialists in this area. And so Vera will tell us about cognitive disorders and possibility of diagnosis and prevention. Dear colleagues, so reducing my presentation, I'd like to say that in most cases, moderate cognitive disorders are considered as some temporary state between normal physiological aging and dementia. That is why this moderate cognitive disorders, it's like a window of therapeutical opportunities to reduce its advancement of some regress depending on the etiology of the syndrome. That's why it's very interesting, and all over the world people are interested in these moderate cognitive disorders. Just the main things. As for diagnostic criteria of this syndrome, according to DCM-5, so it's Diagnostic and Statistical Manual on Psychological Disorders. So there are some subjective complaints that do not reach, that do not disrupt everyday activity, everyday life, and mostly this concerns work or some very highly intellectual activity, and objective verification of this decrease of cognitive functions. So this objectivity is one of the issue, because there is no protocol of examination how to check this reduction of cognitive functions. Often they use some kind of scales, but they can't really detect some deficiencies. So usually they assess 6 most things. So attention, executive functions, education and memory, perceptive and motor functions, social perception, and language. So impressive and expressive discourse. So very important moment of diagnosis is this, the level does not correspond with dementia. Without talking about it in detail, I'd like to say that amnestic type, it can be polyfunctional or monofunctional, has a worse outcome, unlike not amnestic type. And every year there are 10-15 cases that develop into dementia of Alzheimer's type. So, and in this form we have depression twice as often, unlike not amnestic type. Very contradictory data and very variable data related to epidemiology of the syndrome. It's related to the lack of unified scales and unified protocol to assess this reduction from 3 to 42%. So overall, it's 15% for people over 75 years old. We have very good data from 2017 from the guideline of American Academy of Neurology. So they have practice guideline of this moderate cognitive disorders. Usually these disorders develops at 60-64 years old, but you can see it in the circular shape. And then progressively it's increasing every 5 years, and when people are 85 years and older, moderate cognitive disorders are almost at 38%. I'd like to find some research, some prospective study of a good design that would give us some numbers of the back of regress. when the etiology of these disorders are not related with somatic pathologies. And I found such a study of Italian neurologists. So they studied 374 patients within 2 years, and out of all these patients, only 21, and they were younger, well educated, but still some comorbidity. We saw within 2 years the back process of this disorder.
The risk of dementia syndrome. According to American Association of Neurologists, published guidelines, so they assess it at 7.5% in the first year, 15% in the second year, and 20% in third year. This is the dementia risk. So differential diagnosis is quite difficult, and there is absence of symptoms like autosomic mutations or amyloidosis marker. So cerebral amyloidosis biomarkers are not very frequent, and also increasing T protein level and phosphorylated T protein in liquor, and hypometabolism in hippocampus and parietal and temporal areas. Also atrophy of parietal and temporal cortex according to MRI. And it's recommended to monitor the patients at least once every 6 months. So voxicomanometry is used in order to analyze subtler changes of structure. For example, hippocampus that you can see in the top part of the screen. It also becomes one of the major criteria for diagnostics. The reasons of this syndrome could be related to neuroleptics or antidepressants. So these are all reversible reasons of the syndrome. Hypotension, using too many of medication that can produce lacunar infarction, and depression is one of the reasons, but I don't want to stop here because we have short of time. Then hypothyreosis, shortage of B12 and folic acid, hypoglycemia and dehydration, hypothyroidism, sensory loss, and vision loss that affects this syndrome. Obstructive sleep apnea that is also related to neurological disorders. Normal pressure hydrocephalus, which is classified based on the clinical information, clinical data of disease. Atrial fibrillation, if it doesn't go hand in hand with anticoagulants, then it can produce microembolia related to lacunar infarction and infection that can affect intoxication and produce secondary and side effects. Risk factors. Chronic cerebrovascular diseases are considered as the most frequent reasons for vascular disorders. They are mentioned in 60% of cases. Doctors analyze such factors as dyslipidemia, multi-sclerosis, but it's only recently, this paper was published in 2020, that the combination of different risk factors has been identified. And this research was conducted with the use of AI. So they evaluated hemodynamics, that is not introduced widely in Russia, infrared tests, and these tests showed that these patients had lower blood oxygenation in prefrontal cortex, and the combination of metabolic syndrome and hemodynamically insignificant atherosclerosis of cerebral arteries. So here you can see the main areas of therapy, and it includes neuroprotective therapy, reducing vascular risk factors, physical activity and diet, as well as cognitive training. So physical therapy and diet is based on research, and the research was evidence-based and provided a lot of information. Neuroprotective therapy is one of the priority areas to treat moderate disorders. So acetylcholinesterase inhibitors, antioxidants, neuropeptides are prescribed. But in fact, the Department for Sanitary Supervision for the Quality of Food, FDA, does not approve using medication. Most of research on memantine with good therapeutic effect was carried out in Russia. They used open controlled studies, and only one multicentral prospective research was conducted in 2010. They studied 148 patients that received memantine with a dosage of 20 milligrams per day over 6 months. 92 patients were in the group of comparison, so the control group used only control preparate is shown in gray, and the other group is shown in red. Now, inhibitors of acetylcholinesterase, so they were long-term studies that show that these drugs were not effective and had the same result as placebo. A very good effect was shown by actovigin, and I'd love to demonstrate just one research. If you are interested in this research, I'll be happy to answer your questions personally, and I'd love to mention a research conducted in 2017. It was Artemida placebo-controlled research with very good effect. Primary and secondary prevention include different forms of cognitive training, physical activity. According to clinical research, this had a very good design, so the maximum effect was reached in women. and it was related to regulation of glucose and glycogen metabolism, activation of cerebral hemodynamics, and better synthesis of neurofactors, optimization of nutrition. They used liquid biomarkers in their research, so it showed that the diets with low content of fat and low leukemia index for 4 weeks resulted in lower neurodystrophic processes and the level of liquid biomarkers. So diet helped to lower down the lipids in blood. So the primary prevention should include a complex program, including physical exercises, diet, to reduce risk factors, and the progress of this disorders can be slowed down or stopped, but there's not one single pattern of therapy. Thank you. We have discussed the problem of cognitive disorders with Professor Lace, and we did agree that there's no magical pill that could help us to resolve this problem. And we heard many different examples of research, and we do see the effect of our psychologists' work, and we have had of our psychological service here, so this is what they are working with. Thank you once again, Vera. Colleagues, I would like to give the floor to Viktor Savilov. Viktor represents the Clinic of Memory. This program was created by Mr. Kostyukov, so there is a series of such clinics of memory. So you're welcome. Well, my presentation is about clinical practice primarily, because we're speaking about different brain diseases, so our network of clinics demonstrate such practices. And it can build up the foundation for services, cognitive health services, I mean. And I can explain why we connect these things. First of all, it's related to longer lifetime. This is a trend which is common for the whole world. So early diagnostics, prevention, cardiovascular disease treatment, and oncopathology leads to aging of population. And with longer lifetime, we see that the incidence of dementia grows up. So we try to extend lifetime, but it's not always that health remains good, because we have more and more cases of dementia with every year. If we look at economic losses in the world, then we can see it's 1% of GDP per year, $1 trillion. This is the data from WHO. So 3,000 of train cars full of $100 note bills. So health service of the UK published this information, mentioning that dementia made 45%. Then you can see cardiovascular diseases, 15%, oncopathologies, and dementia. So that's why we came up with an idea to set up a cognitive health service, because the extent of this pathology grows. We can call it a cognitive disorder, and it's an anti-stigmatized cognitive disorder. And in Russia, dementia will incur quite a big financial and economic burden. So this burden will be aggravated. And if we take the data from Russian Statistics Agency, we can say that we have 32 million people older than 60 years in 2019. By 2024, we'll have 35.5 million. And it means that the costs will go up by 30%. So what kind of project is it? The Clinic of Memory. Any medical pathology needs prevention. So our project started 4 years ago in 2016, and the objective of the project was to prevent dementia. So we studied the syndrome of soft cognitive decline. So this is the group that is prone to the risk of dementia development, but also it gives us an opportunity for prevention. So the figures can be different, and we wanted to stick to these figures. 30% of syndrome incidence in people older than 60 years old. And if there's no diagnostics and prevention, then 25% of these people would get dementia diagnosis. So now I'll tell you about our Clinic of Memory. So you can see the algorithms and functions of our clinic. We have to select the patients. Usually we have 6-week course of complex program, and these patients come to us daily. We accept about 50 patients. So what happens during the first week? We start with diagnostics in order to determine the cognitive status of the patient. And we use different scales for our research. So we use MMSC, CDT, subjective life quality assessment, etiological scale by Kaczynski, to see what kind of dementia these patients might have. So we used mixed scales, and our physiotherapists examine the physical state of our patients, because they are all elderly people. And then based on this data, we set up groups, and we give we provide different procedures for our patients. They stay with us from 9 to 4 p.m. So you can see cognitive trainings, physiotherapy, healthy food, and medical procedures.
So it's good. And during the stay at this program, each patient receives over 100 hours of training, and it's very healthy, it's very good. By the end of 6 weeks, we make screening through 3 scales. Before we also assess the overall quality of life. And to each patient we give a manual for individual work. Then this manual is like for individual work, 1 hour per day for 4 or 5 months. Then we bring them back and look how they're doing and make a decision about the second cycle. Here's the example of efficiency according to MMSE scale at the first week and at the end. So you see this mild cognitive impairment. At the entrance it's about 90% and at the exit 94%. And of course this efficiency requires scaling, and the tool for that is methodological guidance, where in detail all the stage of rehabilitation and work algorithms of the memory clinic are described. This guideline is published, describes everything in detail what we are doing, and the chief editor is Georgi Kostyuk, who was the curator of the whole project from the beginning. So just to show you some real examples. So here you can see 6 Moscow clinics, and since February 3rd the 7th clinic will open its doors in Kuzminki. So we have different formats of clinics. So clinics are separated from psychological hospitals. Some clinics may be in separate buildings. Some clinics are outpatient facilities. And some are within the neurological dispensaries. So our results, what did we achieve? So the main result is the proven clinical efficiency. So overall we treated over 3,000 patients, and so according to main scales of assessment of cognitive functions we see that overall improvement 75–80%. So this result, there is a result of scaling. We have opened 7 clinics of memory clinics. In 2020 we plan to open 3 more clinics in Moscow. We reached identity, a similar project, so when we check the work at every clinic, and we are planning to open some clinics in regions, Samara, Vologda, Sevastopol and Orel. These are the towns where we so people from these towns were trained in our center. So here we can see the service of cognitive health as a perspective of the development of the project. So before, so this project did not require any additional funding. It was all within, so no additional funding, but for this memory clinic, it's only in one sector, in the middle, but to cover patients in this stage before dementia, we need AI, we need telemedicine technologies, digital technologies, and of course it all requires, so for this integration, so integration with all the departments, with all the services. And of course it requires some support from the government. And of course we'd like that what it looks like in the future, that would be great. the service of cognitive health of nation. I think it's maybe sounds a bit like too much, but it's really necessary in every constituent of the Russian Federation. Thank you very much for your attention. Thank you very much. Wonderful project. And of course, I totally agree that we should develop it in two areas. So any senior person who changed his behavior, like being retired, it's of course very useful. Any activity, any engagement, any involvement in anything. And here you are, and we are in our work. So here we're crossing with the general practice, with everything. But there is another area which is in the whole world is a prerogative of psychiatrists. It's cases of severe dementia, and that's the part that we can see here that it's really needed some further development, especially together with the service, the social service, because it's in the border of social service and medicine. So this moment is quite in demand, but not covered, not fully covered, like some pure psychiatry. So I'd like to wish you success, because that's what's really a big problem, and without this it will be impossible to reach what you showed on the last slide. Thank you very much for your wonderful speech and project. You see, we are moving in a very logical way, independently of the concept. We come into the question that will be the next report, the interaction of neurology and psychiatry, but to say psychiatry and neurology. So you hear all these voices behind. In the corridor, Alla Avedisova is the best who can talk about it. She doesn't need introduction. We are very happy that our department works in our clinic. We can't imagine our existence without such an interaction with the institute where she works. We are very happy that she will tell us about this interaction. Dear colleagues, I'd like to tell you that there is an issue of necessity of neurologists and psychiatrists interaction, and this problem is started quite a long time ago. So there was an interesting study by WHO that was conducted in 20 countries in the world about the spread of psychiatric disorders. It started in 1998 and it was finished in 2004. So in 20 countries, about the spread of the psychiatric disorders. And what were the conclusions that they made? That psychiatric disorders are the most spread types of chronic diseases. So within life up to 50%, and within 1 year up to 25%. And psychic disorders usually start much earlier than any other chronic somatic disorders, and usually they are unidentified by psychiatrists. So this shocking data, shocking results for many people, they started. So 1 in 4 people is under stress. It has a risk of developing a psychological disorder. So here we can see, so some cafes were open, 1 in 4 movies, music, discs. So a lot of things all related, so it was like a whole meme, 1 in 4. But now, if we have a look, like almost 10 years after the study, so where we went from the psychiatric point of view, everywhere when we detect some spread of psychiatric disorders, they all find about the same figures. So, for instance, here's the clinical department in Kazan. They study up to 50%, 50 disorders. Here it's in another hospital and pulmonological department. So hypochondria it's up to 30%. So numbers are really high. So here otorhinolaryngology 38.5%. So Republican Clinical Hospital in Kazan, you can see very high numbers of the spread. Of sub-threshold and threshold states related to psychiatric disorders. So about neurology, neurologicals in patient clinic. So it's not in Russia. So almost 30% of people with affective disorders in neurological inpatient clinic. But the main issue of such a huge amount of people with psychiatric disorders is that they don't come to specialists. They don't even go to the right proper medical care, standardized medical care according to recommendations. So the studies that were conducted about the roadmap of patients up to the first standardized psychiatric care, we can see that where people go first of all. First of all, they come, maybe you can see it, mostly they come to neurologists. So to all the specialists, but mostly to neurologists. When there is social phobia, panic attacks, generalized disorder, quite a big amount of people come to be treated to neurologists and other specialists. For instance, on the internet we can see, I really like this quote, I think it's very indicative. So a cardiologist says, treat your brain, for instance, amitriptyline with grandoxine. So do cardiologists understand psychotropic treatment? Neurologists said that it's autonomous neurosystem dystonia through hypotonic type, and insist to take azafin. First psychiatrist who prescribed Paxil diagnosed masked depression. Second psychiatrist who prescribed Aglanil put hypochondriac neurosis. So, and says that I don't have depression, so what should I do? So such states, such patients who can't get proper help, proper care, so they raise this question about the necessity of interaction between neurologists and psychiatrists. So we made a focus group. So one with neurologists, that I organized it with 6 neurologists and with 6 psychiatrists, who from our point of view showed 2 points of view of neurologists and psychiatrists related to the same patient. So it was according to all the standards, transcripts, video recordings, and so on. So we asked a couple of questions. Here I'll show you some of them. What percentage of patients with anxiety and depression come to you within a month? And you see about the same percentage. So anxiety and depression that come to the doctor in clinic patient. So on the left neurologist, on the right psychiatrist. Do you consider patients with anxiety and depression hard, difficult patients, and what are the difficulties? So what neurologists say? They take too much time. They quite often disagree with the sources of their problems, have functional character. They insist on different studies like MRI. They do not comply with prescribed recommendations. They do not agree to consult psychiatrists. So pay attention that both neurologists and psychiatrists consider these patients difficult. But psychiatrists talk about those who do not believe in therapy, who stopped using any therapy, who are too much informed about side effects, who don't come for follow-up, and those who, due to severity or comorbidity, require specific therapeutic approaches. So neurologists see the problem of compliance, psychiatrists see the problems of resistance, of inefficiency of therapy. So the next question, do you consider possible to treat these patients on your own? For instance, when they have vascular pathology and comorbid depressive disorders. And which patients do you refer to a psychiatrist? Or to neurologists if it's a question to psychiatrists. Neurologists don't see any problem with independent treatment of such patients, and they think that they can do it quite well on their own. Psychiatrists also think that it's possible for them to treat such patients without consulting neurologists, so they prescribe all the therapy, and sometimes they correct the therapy prescribed by neurologists. And each of these doctors treat a patient by their own methods, by their possibilities, without any interaction with each other. Then we asked another question, without some other disorders. So here neurologists talked about the necessity of all kinds of studies when there are some increased heartbeat, headache, weakness, increased BP, cold sweat. So they understood that it has functional character, but they wanted to make all kinds of studies, all kinds of tests, like MRI, ECG, and still didn't talk about referral to psychiatrist. So they prescribed some non-traditional therapy methods, like to breathe into the pocket, into the paper bag, some spray under tongue. Psychiatrists highlighted the treatment with antidepressants. But when discussing therapy, neurologists and psychiatrists, it was clear that they have their individual preferences of these doctors, and they are based either on their experience or on some very discrepancy, on different data, knowledge that they get from literature, but not on standard treatment for both psychiatrists and neurologists. So last question was, so we wanted to understand, is there any compliance between neurologists and psychiatrists? There was no compliance. Neurologists thought that referral to a psychiatrist requires a lot of interaction with the patient, and they don't have time for that. And psychiatrists thought that neurologists can only treat patients with subsyndromal patients, but not with psychiatric disorders. It allowed us to say that there is such an issue with this interaction. It requires a lot of attention to achieve this interdisciplinary compliance when doctors should work together, neurologists and psychiatrists. And as a model, Allah created in her center. Thank you very much.
Thank you, Allah. We were working as a team, and you did a great job. All our patients go for consultations with different specialists, so we don't really have this problem related to interaction between different specialists. We have a license for education. Marina is in charge of education programs. So we have several education programs. Visit our website and you will see that it's regularly updated. So we are delivering different programs together with our international colleagues. And of course, the cooperation between neurology and psychiatry is extremely important, and Nikolai, as a chief neurologist, knows this, because this is our professional competence. Thank you once again, Allah. And you know, our session is called From Basic Science to Clinical Practice. But it turned that we started with clinical practice, and finished with basic science, and it's part of our work together with the Institute for Medical and Biological Problems. So Ekaterina Karimova will introduce and present our research, which is about one of the most interesting problems related to interpersonal relations, because again there are different modern methods of neuropsychology that can take measurements and assess the situation. Thank you. I'm happy to present our research about mirror neurons in patients with different psycho and neurological disorders. First of all, I would like to explain what the mirror neurons are. So these neurons become more active. So when the person sees some movement, or when the person repeats the movement, these mirror neurons were discovered in monkeys when they experimented with their cortex. So Rizzolatti, an Italian scientist, noticed that certain neurons increase their activity, and when the researchers that conducted this experiment showed something to macaque, then the macaque would do the same. But if the researcher did something with forceps, then the monkey could not do it. So I'm going to tell you about the functions of these mirror neurons. You probably understand the function and the areas where they can be used. First of all, they can be used for training, and because they can help you to cooperate, and it works very well with children. So adults use it for social interaction, because it helps us to understand motivation of other people better, and we can feel their emotional state and be in tune with it. So when an infant is looking at an adult and the adult shows some gesture or claps hands or smiles, the infant has a responsive reaction. The infant wants to repeat the same action, and here we can see the connection between sensory input and motor response. So mirror neurons are intermediaries between this. It was discovered that when the emotional faces are shown, we can observe activity not only in the frontal cortex but also in the right island share. So it means that there is the very important function between our emotions and motor function. When we know about the function of mirror neurons, it makes us think about autism. We know this disease and we know how it is articulated. So when the properties of mirror neurons were discovered, the scientists began to study autists to see what kind of activity in neurons they have. And it's true that mirror neurons have less activity in such patients. But it's not quite clear whether it's the cause or the implication of this. So mirror brain system plays a very important role in education and understanding actions of other people. So we can call it a substrate of our social behavior. Electroencephalography is one of the methods of studying mirror neurons activity. For example, neurism can be registered with EC, and neurism power goes down when the person imagines a certain movement, and that's when mirror systems gets activated. And it means that the change of rhythm is an indicator showing us mirror neurons, and we can examine it for different purposes. So we started working with patients with affective disorders. The first methodology that we used is hand movements, demonstrated by the doctor. So the patient had to observe it first, then to imagine it, and then to repeat it. And later on, the patient and the doctor had to make this movement. And you can see the results of changing in rhythm. So red columns mean healthy people, and blue indicate patients. So we can see the changes of rhythm happen in healthy people. But when they had a sensory reaction, when they not only observed but also did something, the patients activated their mirror neurons, and so they became more active. And this slide shows Loretto program and the results. So the areas were more diffuse, and it covered the bigger part of cortex, and control group had a more localized activity. The second research that we carried out was dedicated to patients with epilepsy because they suffer from high social disadaptation, and some patients go for the removal of the focus of disease, and invasive electrodes are put in their brain. So that's why we could use this for our research. And we wanted to improve our methodology and make it more standardized, remove a subjective factor. That's why we made a video with 3 different movements: clapping hands, taking a cup, and compressing the palm. And I would like to start with electrodes. So as you can see, the electrodes are located at different depths. So we can see activation of mirror neurons in most cases. As to surface neurons, they did not demonstrate the same ability. This happened in left hippocamp. As to right hippocamp, they showed an increase in neurism. So these electrodes showed activity in some local area, and this effect can be related to the fact that some areas were filled with mirror neurons and some others were not. And here you can see the results of our electroencephalogram, and we wondered why we didn't have a lower neurism, because people with epilepsy do not show the decline of neurism. It means that the system of mirror neurons is not activated. And then we realized that we use different methodology. We demonstrated stimulation material with a video, whereas in the other example, the movements were demonstrated by a doctor who was sitting in front of the patient. And we decided to compare those 2 methodologies. We invited healthy volunteers and saw this. When the doctor demonstrates the movement, the neurism goes down and mirror neurons become activated. And when people see the same in video, this doesn't happen. And this was new information for us because it made us think, and it made us think about so many things that we lose when we interact online through the screen. So it's related to emotions of other people and understanding them, their motivation, and trying to be in tune with this person, as well as education through imitation. We feel that many people live online, and maybe we'll lose a lot in our interaction. So this is some food for thought. Thank you. I would like to thank you, as well as Natalia Lebedeva, who is a professor of Institute for High Nervous Activity. We cooperate with them a lot. Thank you very much, colleagues. I'd love to thank all the lecturers, all the speakers. My congratulations to the best neurologist of Moscow. We have run out of time, but the speakers will stay here for some time. So if you have any questions, you can come and ask, because we won't be able to take questions from the audience at the moment. Anyway, if you need more information about our center, you can find it in these leaflets. And I would like again to invite you to our international conference on the 1st and the 2nd April. Thank you.